Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Until recently, the inflammatory myopathies, things like dermatomyositis, immune-mediated necrotizing myopathy, and antisynthetase syndrome, have all been treated the same way. You suppress the immune system. You give patients steroids, methotrexate, azathioprine, maybe mycophenolate. Sometimes you reach for IVIG or rituximab. And sometimes that works. But the deeper question has always been whether we can do something more precise, whether we can actually treat the biology driving the disease, rather than just broadly shutting down the immune system and hoping for the best. Because the truth is that the inflammatory myopathies aren't really one disease. They're a group of biologically distinct syndromes. They look different clinically. They behave differently. And increasingly, we're learning that the immune pathways driving them are different too. And if that's true, then instead of treating every patient with the same cocktail of immunosuppressive drugs, we might actually be able to target the specific immune pathways driving a particular patient's disease. That shift from empiric immunosuppression to biologically informed therapy is exactly what this episode is about. My guest today is Dr. Julie Paik, Associate Professor of Medicine at Johns Hopkins and co-director of the Johns Hopkins Myositis Center. We talk about how clinicians diagnose the inflammatory myopathies, why these diseases are still frequently misdiagnosed, and why dermatomyositis in particular has become a proving ground for targeted therapies. We also discuss one of the most interesting developments in the field right now, a large global clinical trial studying brepocitinib, an oral small molecule inhibitor of TYK2 and JAK1, two key signaling proteins involved in interferon pathways that appear to drive the inflammation in dermatomyositis. The study enrolled more than 200 patients with dermatomyositis and represents the largest clinical trial in the history of the disease. So today's conversation isn't just about one drug. It's about a broader shift in how we understand and how we treat the inflammatory myopathies. Enjoy. Julie, welcome to the show.
Great to be here.
So we're going to be talking a lot about inflammatory myopathies, especially about these novel treatments that are up and coming. But before we talk about those treatments, it's always great to give a background to our listeners about what are these inflammatory myopathies and how do they clinically present?
Idiopathic inflammatory myopathies or myositis are a group of systemic autoimmune diseases where the immune system targets the skeletal muscle, but they're also it's a really multi-system disease. So they can also affect more than just the skeletal muscle. It can affect the skin, the lungs, joints, and even sometimes the heart. And clinically, patients usually present with progressive proximal muscle weakness, and they have difficulty climbing stairs, getting out of a chair, like lifting overhead. But I think the phenotype really varies depending on the subtype. And I think one of the biggest lessons in myositis over kind of like the last decade, I would say, is that it's not just like one disease, but they're like a group of biologically distinct syndromes. So like we think about dermatomyositis, antisynthetase syndrome, immune-mediated necrotizing myopathy, and inclusion body myositis as distinct, like different entities or subtypes within this IIM or idiopathic inflammatory myopathy.
Oftentimes, at least in the inpatient setting, we get called to evaluate patients for inflammatory myopathies when patients have muscle pain. So how much is pain part of the presentation of these inflammatory myopathies versus proximal muscle weakness, as you mentioned?
Yeah, no, that's a really good question. A lot of our patients do report muscle pain, but I think we're taught in when we're baby medical students that myositis patients don't get muscle pain. But in reality, especially in dermatomyositis, and it's even reported in mu-mediated necrotizing myopathy, because the fascia layer, which is right over the muscle, can actually have quite a bit of nerve fibers. And if you
Mm.
have muscle edema and fasciitis, which is very common, it's like the fascia sitting right on top of the muscle, you can get quite a bit of muscle pain. So it's not like never, but you could definitely have muscle pain. Yes.
Got it. But the weakness is sort of the main sort of presenting sign in patients with inflammatory myopathies. And you mentioned proximal muscle. So climbing stairs, how else do you see it?
Reaching overhead, I was always asked about like drying your hair or, getting plates overhead, like if you're cooking or something like this
Hmm.
in a cupboard, getting out of a chair. Yeah, lifting overhead, things like this. Yeah.
Okay. Great. And then you mentioned several different buckets, different types of inflammatory myopathies. I
Mhm.
think you said dermatomyositis, the immune-mediated necrotizing myopathy, antisynthetase syndrome, inclusion body myositis. Is there still polymyositis? Like, does that thing really exist anymore?
We've had like these great debates in our myositis communities, so to speak. So there's kind of two camps, I would say. One believes that it does still exist, but I would say most believe that it does not exist. And it's really a diagnosis of exclusion
Hmm.
because if you think about the old 1970s Bowen and Peter criteria, it dichotomized myositis into just DM and PM. But in reality, probably it was like a very sensitive way to classify myositis, but not very specific. All of those patients who probably had either immune-mediated necrotizing myopathy or inclusion body myositis were lumped into polymyositis. And so that's why we really say, I think it's really evolved now. It's really a diagnosis of exclusion.
Got it. How do you differentiate between all of those different entities? Is it the sort of the clinical findings? Is it what you see on antibody testing or a little bit of both?
I would say it's a little bit of both. Right now, the literature is really supporting that the myositis specific autoantibodies and the myositis associated autoantibodies are really more predictive of phenotype and their presentation and disease course than like muscle histopathology. But like you said, it's kind of a little bit of both because the muscle biopsy features also are very unique and specific to each of those subtypes. Like dermatomyositis, you'll get perifascicular atrophy versus antisynthetase syndrome. We know it's been reported it's more perifascicular necrosis.
Mm.
Immune-mediated necrotizing myopathy, you will have more necrosis with regeneration, degeneration of the myofibers. And inclusion body myositis have rim vacuoles. And even polymyositis, really the kind of exact way to say you have polymyositis or more correct way is that you have primary inflammation of the myofibers, but still is a diagnosis of exclusion. Yeah.
Got it. So you're relying a lot on those antibodies and sometimes on the biopsy. Do you need to biopsy every patient? Do you biopsy every patient with inflammatory myopathy?
No, I do not. So I think in dermatomyositis, because the rash is so classic, we're
Mm.
like, we really don't need to have a muscle biopsy to make a diagnosis of dermatomyositis. I think if you have quote unquote polymyositis and you have no extramuscular features, I think the muscle biopsy is, we definitely do the muscle biopsy, especially in the absence of a myositis autoantibody.
Mm.
But I think it's really trending forward in a sense that if you have classic symptoms of myositis and you have a myositis specific autoantibody like anti SRP, then do you really need to have a muscle biopsy? Is the question. And I think right now it's not absolutely necessary. But if you ask a neuromuscular specialist, I'm sure, right? They would want you to get a muscle biopsy. And I think it is safe to do that when you're not sure about the diagnosis, especially if you don't have an autoantibody to guide you.
How much do you rely on imaging
Oh, to make the biopsy or to
to
kind of
make the
put the diagnosis?
diagnosis?
So muscle MRI is what we use classically, the T2 stir sequence to look for muscle edema. And it does help, but it doesn't make a diagnosis of myositis. we say that it shows us muscle edema, but it can't really tell us if it's necrotizing or dermatomyositis. You're going to see the muscle edema and fasciitis in any of these subtypes. So I would say it's another diagnostic tool to guide us and make a diagnosis, but it's not the only tool we use.
Okay.
Yeah.
Great. So we talked considerably about sort of the presenting symptoms and signs of the myositis aspect of it. But you also mentioned that there are other extramuscular features with some of these conditions. Do patients sometimes present with these other features first? Or what are the typical symptoms that they present that suggest they have extramuscular manifestations?
Yeah. So I would say the anti-synthetase syndrome, usually like PL12 positive or PL7 or anti-Jo1 positive patients who have anti-synthetase syndrome, where you get the myositis and anti-synthetase antibody. And ILD is usually kind of the presenting symptom in some of these patients. So a pulmonologist may see them first
Aha.
before we even get involved.
Once you diagnose a patient with one of these inflammatory myopathies, how do you think about treating them? Does it matter the flavor of myopathy that they have? And do you adjust treatment? Oh, it's dermatomyositis, so I do this, and it's necrotizing, so I do this other thing. Or do you sort of treat them all the same?
Yeah, I think we're really at the precipice of how we are approaching treatment. It's definitely changing. Right now, like if you think about the old way we treat, and I think we still do that, or the historical way, is that we really relied on like corticosteroids and steroid sparing agents like methotrexate, azathioprine, or mycophenolate. And we usually use one of those steroid sparing agents first with steroids at the same time. And then I think we then add an infusion therapy, for example, if they are not responding to those agents after 3 to 4 months, like IVIG or rituximab. And in particular, IVIG has been approved, FDA approved for dermatomyositis in the past several years. But now it's really changing. I think, the field is evolving, as I said, and it's really changing in a sense that we're targeting the mechanism
Hmm.
of each subtype. What is a driving mechanism of muscle inflammation in each subtype? Like, for example, in dermatomyositis. So I think we're finally moving from empiric immunosuppression to mechanism based therapy in myositis. Yeah.
That's super cool. So currently you're doing that. Currently you're treating your DM patients different than your anti-synthetase patients.
Yes. But we're very close, I would say. Like,
Very good.
because and this will come to, like, some of the recent trial data that has been, released. But we know I think the classic example is, like, dermatomyositis, where we know it's the clearest signal of type 1 interferons driving immunopathogenesis. So if you
Ah,
can target that directly, then I wouldn't even have to go and start with steroids and
oh,
methotrexate
amazing.
and azathioprine, things like this. We've done, and many others have done, proof of mechanistic studies showing like pre and post after treatment. If you give a drug that blocks interferon, then certainly their skin, muscle kind of all improve. So I think that's the classic prototype of where the mechanism is really driving
Super cool.
treatment.
What happens if you don't treat these patients? Do you ever have patients that say like, I'm a little weak, I don't want to treat? What's the sort of long-term outcome
Oh, when they say they're not that weak.
of inflammatory myopathies? Like, do they all need treatment? And what's the typical, what happens if you don't treat them?
I think they tend to get worse, but there's like this kind of spectrum. I think there's this heterogeneity of myositis that we is challenging for us because there are patients, like you said, who have like a myopathic dermatomyositis where they only have mild skin disease and absolutely zero muscle involvement. So
Hmm.
I probably will never even lay a hand on that patient, but a dermatologist is treating them for their skin disease and it may not even be that severe. They might just have mild Gotrins, and it's a little itchy here and there and red, but they'll just put some steroid cream on it and they never get any muscle involvement.
Hmm.
So I think it's heterogeneous. But if someone does have muscle involvement, my experience has been that it will continue to progress And the rate at which it progresses is, I think, different across different subtypes. Yeah.
Got it. Yeah. Sometimes we get questions is like, oh, this patient has had muscle pain and slightly elevated muscle enzymes for like 10 years. Is this an inflammatory myopathy? Often I'm thinking like, well, if it were, they'd be pretty sick. They'd be pretty weak. Do you think that's sort of the typical what happens to these patients over
Oh, yes.
time?
Yes.
Yeah.
I mean, I think there are patients who have like hypercikaemia, which is
Hmm.
another, probably needs another podcast.
We should. That's actually an interesting topic. It's such a common consult question, right? Like, oh, this patient,
Right.
CK is 500 or 1,000,
Right.
right? Is this
Right.
inflammatory myopathy?
So when someone has elevated CK for like 10 years, like it's probably not going to be myositis.
Hmm.
Unless someone has like, again, hypomyopathic dermatomyositis and they're just like extremely mildly weak. Well, I mean, they're not weak, but they have mildly elevated CK and some mild goat trends, and that could just like linger over time for 10 years. But normally, if someone has elevated CK in the thousands, we at least do a one-time workup, even if they're fully strong, to do, and you check it again, it's still CK is 2000. You should have at least probably do like a EMG and a muscle MRI to see if there is edema and even consider a biopsy if it's like new onset. But if it's 10 years and they're very strong, I
Hmm.
don't think so.
All right. So let's talk about the menu of options out there for treating these inflammatory myopathies. You mentioned steroids that are sort of have been the backbone of therapy. You mentioned DMARDs like methotrexate, azathioprine. You mentioned IVIG. Is that the only like FDA approved medication for inflammatory myopathies?
Yes. So far, that is the only one that is FDA approved for dermatomyositis
For
specifically.
DM, okay. So that's not approved for any of the other inflammatory myopathies?
It is not. Yeah, that
Uh,
Proderm trial, I think was published in 2022 in the New England Journal of Medicine, was only in dermatomyositis. But we do use it off label for necrotizing all the time. But sometimes insurance will give us a hard time too. I think
mm,
yeah, this is challenging. Yeah.
okay. And what are sort of the treatment gaps in the management of these inflammatory myopathies? Why aren't we doing a better job in managing these conditions? What are the gaps in terms of sort of treatment options?
Yeah, I think the first major gap is delayed diagnosis, which still
Mm.
happens frequently. I mean, I had a patient in the past year who was misdiagnosed as having a muscular dystrophy.
Oh my goodness.
And so, yeah, being misdiagnosed with a muscular dystrophy and so young. And it was because she had a muscle biopsy that was read incorrectly. And no one ever decided to order a myositis antibody panel. And the patient herself was like, I Googled this and no one checked this for me. And her CK was like 20,000. And of course, she's young and she Googled it and she asked her primary care to order it for her and she was SRP positive.
Oh
I mean,
wow.
she had literally like dropped out of grad school. She was so weak. She couldn't go to the gym anymore. And so she actually saw my colleague, a neuromuscular specialist at Hopkins. And then my friend and colleague was like, this is not a muscular dystrophy. Her SRP titer is high. Anyway, so I treated her and she's doing great now. And another lack is like, we don't have like predictive biomarkers per se.
Mm.
I think these autoantibodies may guide us and be like, oh, this patient may respond to X drug, but I wish we had another biomarker that would be like, we know this patient will respond to this exact therapy. And then until recently, as I was talking about dermatomyositis as kind of the clearest example of, type 1 interferon being very important in disease pathogenesis, we don't really have like modern targeted therapies, I think. But I think
Mm.
the encouraging thing is that the therapeutic pipeline is expanding rapidly.
Is the goal of therapy like remission? With the current therapies available, do you get patients into remission and what does that look like?
Yes, we do get patients into remission, but not always. I would say it's a little more rare. And when they do get into remission, our definition of remission is being on like medication induced remission. So being
Yeah.
on a DMARD without the need for any steroids for a flare for at least 1 year is basically our kind of gold standard definition for remission clinically.
And with like
Um,
normal muscle enzymes and normal strength?
I would say normal muscle strength, normal muscle
Normal
strength,
muscle strength. Okay.
because there
Good.
are patients with like immune-mediated necrotizing myopathy where their CK was like 100,000 at presentation. And then we've seen this over the years where then their baseline is like 1,000 or
Yeah.
1,500, but they're so strong doing
Okay.
everything.
So it seems like with our current therapies, we can get some patients into remission. So what happens to the other patients? Do they get progressively weak or do they just need lots of steroids and suffer side effects from that? Like what happens to those patients that don't reach remission with our current treatment?
Yeah, we usually go like every 3 to 4 months after if someone fails or they have an incomplete response to one of the DMARDs, then we add an infusion therapy and then reassess. If you don't respond to infusion therapies like IVIG or a B-cell depleting therapy, then we really move on to clinical trials.
That's a great segue. Let's talk about clinical trials, Julie. I know that you were recently involved in a large clinical trial that tested this new medicine, brepocitinib. I believe it was for patients with DM. Is that right?
Yes, that's
Talk a
correct.
little bit about how this trial came about and who the patients were and what you guys did with these patients.
So there's been a lot in the literature, as I was saying, about how important type 1 interferons are in disease pathogenesis and dermatomyositis. We also conducted a proof of concept trial using a JAK inhibitor in refractory dermatomyositis, specifically tofacitinib. And those patients had a really good response that we were able to show in the skin and in the muscle using muscle transcriptomics and transcriptomics in the skin that type 1 interferon was clearly downregulated.
Hmm.
And that was coming out in the literature many places, internationally and in the US. And then a company had decided to move forward with a newer JAK inhibitor or TYK2 JAK1 inhibitor. And the drug name is obviously, as you said, brepocitinib. And it targets more cytokine signaling pathways specific to type 1 and type 2 interferons. And so instead of broadly suppressing the immune system like we discussed with previously, it's actually targeting that central pathway of blocking type 1 and type 2 interferons. And I think that's an important conceptual shift in the treatment of inflammatory myopathies. Yeah.
Huh. Okay. So again, targeting type 1 interferons, which you mentioned, is more particular for the DM. And that's why the study was made for patients with dermatomyositis as opposed to some of the other ones. So, who were the patients that you were able to enroll? Were these patients that had DM for a long time or newly diagnosed? Can you talk a little bit more about that?
The trial of brepocitinib in dermatomyositis is a global multi-center trial that had about over 200 patients. This is the largest trial in myositis to date. And it included only dermatomyositis patients, and you had to be on at least one stable background therapy. You didn't have to be early in your disease. You could have had disease more than 3 years, but you did have to have active disease entering the trial. And the trial was a 52 weeks trial, which is longest myositis trial to date, which was required by the FDA. I thought that was really challenging, in terms of recruiting, but we were able to do it. And I think that it was hard because IVIG was already FDA approved for dermatomyositis, and patients were not allowed to be on IVIG entering the study.
So, was this a placebo controlled trial?
Yes, it
Okay.
was placebo controlled, and there were 2 dosing arms.
You have the doses of 2 doses of brepocitinib, you have placebo. And
Mhm.
were they on anything else? Could they be on DMARDs or steroids?
Yes, they could be on one background agent,
Meaning
meaning
a
one
DMARD,
DMARD.
one
Yes,
DMARD. And could they be on
yes.
steroids?
You could be on steroids. It's pretty standard for our myositis trials. You can be on up to 20 milligrams of steroids.
Okay.
Oh, and one key part of the trial was that there was a mandatory steroid taper built
Oh,
into the
amazing.
protocol. Yeah,
Super.
which was phenomenal to see that patients were able to taper the steroids. Like, I think
Yeah.
over
Yeah.
50%
Because
of
otherwise you
patients.
just keep the patients on placebo on steroids and you
Yes.
can't really tell the difference. Okay. So tell us about the results of the trial. That's very, very exciting.
Yes. So basically, all of the patients in the trial, so there were, as I was saying, over 220 patients in the clinical trial for this Valor trial. And it met the primary endpoint and all of its secondary endpoints, which was phenomenal to see. And the primary endpoint is the total improvement score that we use in all of our myositis clinical trials. And it's a composite score that includes the physician global, the patient global, the extramuscular global activity, muscle strength testing, a muscle enzyme, and also the health assessment questionnaire, which is assessment of disability. But robustness of the primary endpoint was seen with the 30 milligram arm, Brepo 30
Mm,
milligrams, and the efficacy was seen as early as 4 weeks and sustained out to 52 weeks. Yeah, I think that's pretty phenomenal. Yeah.
it's pretty amazing. What about the safety of this new drug, brepocitinib?
Yeah, the safety, I think all of us were very curious about the safety, but all in all, when you look at the safety and compare across placebo versus the 30 milligram arm and the 15 milligram arm, we really didn't see any MACE events in that 52-week study period or higher risk of cancer, anything like this, which was really reassuring. But of course, we'll have to wait for like phase 4 to see. Yeah.
Okay. Where is this drug sitting? Is the company applying for like FDA approval for this drug in the use of for dermatomyositis?
Yes. There was another press release that just came out, I think this past week, and the FDA has the application and they
That's good.
stated
Step one.
step 1, they stated that they will undergo a rapid review. So
Mm,
normally, I guess it takes about 9 to 10 months, but it will be by August, late August, we will see if it is FDA approved or not.
okay, amazing. So, Julie, the several press releases, there was a presence at the ACR convergence. Certainly, the company was there talking about the results of the Valor study, and there were some presentations about this. But the formal manuscript hasn't yet been published. Are there plans for publication soon?
Yes, the formal manuscript has not yet been published, but it has been accepted for publication.
Amazing. We look forward to reading it soon. If and when this drug gets accepted,
Mm.
among the various treatments that we've discussed about treating, I guess, dermatomyositis for now, how do you envision that clinicians should be using this drug? Should it be sort of first line treatment? Should it be for the people that fail infusion therapy or the people that just fail GMARDs? How do you think this might fit into the treatment landscape?
That's a good question. I think in the classic sense, because the patients who met the inclusion criteria to enter this Valor trial, the phase 3 trial, you had to be on at least one background agent like methotrexate or azathioprine or mycophenolate, and then brepocitinib was added on and it showed efficacy. So I think in the classic sense, using the trial data, you would want to have someone on background and they're not doing well, not getting the best response, then you would add brepocitinib onto the background agent. However, I would like to challenge that if we know the pathogenesis of dermatomyositis is clearly type 1 interferon driven, and by blocking the JAK-STAT pathway, you can downregulate type 1 effectively, as we can see with this Valor trial, then I think there will be a role for treating it in patients who are naive to treatment or as first line. And I think a lot of dermatologists are already doing that using off label JAK inhibitors for skin predominant dermatomyositis. But the question is if someone actually has more skin versus skin and muscle, then maybe adding a JAK may be more efficacious, but I don't think we really know.
And would you envision brepocitinib being tried in some of the other inflammatory myopathies? Do you think that there is a role for that specific drug? Or do you feel like because of the pathophysiology of necrotizing myopathy or anti-synthetase syndrome that it may not be as effective?
No, I think that's a good question. I think in immune-mediated necrotizing myopathy, I don't think it will be efficacious. We really think myositis autoantibodies potentially are playing a more direct role in immune-mediated necrotizing myopathy. And so I don't think blocking JAK-STAT pathway and downregulating type 1 interferon being very successful in immune-mediated necrotizing myopathy. But you do ask about anti-synthetase, and there is data to show that even in the muscle biopsies of these patients who have anti-synthetase syndrome, so those who do have muscle involvement, there is some upregulation of type 1 interferon. So it may be potentially beneficial if they
Hmm.
received a JAK.
And do you know of other sort of drugs in development or pathways that are being targeted for the treatment of DM or some of the other inflammatory myopathies?
Yeah, no, actually, I think there are multiple other drugs in the pipeline. And one of them is a FcRn inhibitor that is being looked at across dermatomyositis, immune-mediated necrotizing myopathy, and quote unquote polymyositis. And they just finished recruiting for the phase 3. So
Mm,
hopefully we'll see the results of that. And I also have a special interest in immune necrotizing myopathy. I'm the principal investigator of a UM1 funded clinical trial. And this is through the NIH Autoimmunity Center of Excellence Network. And we're targeting patients in this phase 2 multicenter trial who have immune-mediated necrotizing myopathy and they're anti-SRP and HMGCR positive. But we really want to try to give them rituximab, which is a third generation CD20 agent, early in their disease to hopefully
mm,
just shut it off within the
mm.
first year of disease. So, like early combination therapy, can that actually change the paradigm? Because I think we are right now doing like empiric step up therapy,
Yep.
but why don't we just treat it aggressively, especially in those necrotizing patients where they get early fatty replacement even within like the first 3 years of disease?
Yeah.
It's truly unmet need. So I'm really actually trying to recruit for this trial.
Amazing. No, that sounds like makes a lot of sense. And I guess going back to how the pathophysiology of these various diseases can help you think about targeted treatments, I think it makes a lot of sense. This is immune mediated, so antibody mediated destruction, then just get rid of the antibodies and see if that makes it better. Amazing. Julie, thinking ahead sort of 5 years from now, how do you think the treatment landscape of the inflammatory myopathies is going to look like? How are we going to be doing things better?
Yeah, I think the biggest change, like in the next 5 years, where will be that we'll move toward more like biologically informed treatment strategies instead of treating all patients the same way. We'll increasingly tailor therapy based on disease subtype, autoantibody profiles, and underlying immune pathways.
And for trainees out there that are interested in getting involved in myositis research, what do you think are the biggest questions that remain? What are the things that nag you on a day to day basis that you wish were resolved?
There's so many questions. I mean, it could range from what is the true trigger of myositis?
Mm,
I don't think we really know. Obviously, we know about statin triggered myositis, immune necrotizing myopathy, but certainly not everything is statin triggered, and we still don't know why. And then that's one. I mean, I don't know. There's so many.
I like that. I'm so interested in sort of the thinking about why patients get rheumatic diseases in general, right? It's
Mhm.
such a conundrum. Like, we know that, yes, there's probably some genetic predisposition to some of these diseases. And yes, there's probably some environmental triggers. And yes, in some cases, there may be some infectious trigger that does it. But what is it that makes patients develop this thing that it seems like, at least for now, like once the immune system has been sort of triggered, the patient will have chronic disease long term. Oh, last question. CAR T cells. Do you think that's a potential treatment for patients with inflammatory myopathies?
Do think so, especially in refractory immune-mediated necrotizing myopathy, because there are some patients just they don't respond to treatment, especially immune-mediated necrotizing myopathy. I think there is a role, but I'm not so sure about in dermatomyositis because there's so many drugs coming out, as we discussed with the Valor trial, but I think there is a role. Time will
Great.
tell.
Julie, this has been an awesome conversation. Every time I chat with like an expert like you, it's just awesome. I can't wait to get back into the clinic and start seeing patients with inflammatory myopathies and trying to apply some of the things that you mentioned. And certainly I look forward to being able to use brepocitinib in my DM patients in the future and thinking about how I can target my treatment depending on the type of inflammatory myopathy that my patients have. So this has been really valuable. I'm sure that the audience also learned a lot from your experience. So congrats on the hard work. Congrats on getting the Valor study published somewhere. We all look forward to reading it when it comes out.
Awesome. Thank you so much for having me.
One of the things that stood out to me in this conversation is just how much the field of inflammatory myopathies is beginning to change. For decades, treatment has followed a predictable pattern. You start with steroids, you add an immunosuppressant, and if that's not enough, you escalate to IVIG or rituximab. But it's always been a bit of trial and error. What Dr. Paik describes is a shift away from that model. Instead of treating all inflammatory myopathies as if they're the same disease, researchers are beginning to understand them as biologically distinct syndromes, each with different immune pathways driving their inflammation. And once you start thinking about these diseases that way, the therapeutic possibilities expand quickly. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars or however many stars you think we deserve. Show notes for this and all other episodes can be found at acronair.org, on Apple Podcast, Spotify, and on your favorite podcast app. Until next time, keep targeting the pathway, not just the problem. And of course, stay healthy.
This podcast was edited by Resonate Recordings.